pediatric cardiologist whom I have tried to kidnap from Dr. Suleiman to Tawan Hospital, but I failed the first round, so the competition is open. He's working at KidsHeart, American trained and board certified. He's going to talk to us about sudden cardiac death in children and young adults.
Thank you, Dr. Walid. It would have been an honor to work with you. Today I'm going to talk about sudden cardiac death in children and young adults, and with insights into genetics. So why I'm presenting this here? Because sudden cardiac death in children is actually very rare. It's rarer than rare diseases. It happens 1 in 100,000 to 200,000 in the population. This is a recent video from the United States. This is a volleyball, so it's not a very, let's say, contact competitive sport. Look at this here there, in the background. She's suffering a sudden cardiac arrest episode. And you can see the training, very good training of the coach. The first one just cleared and stepped away because he doesn't know. The second one immediately recognized there's a problem. Called 911, so as your BLS, started CPR immediately. But the most important step that would save this child's life is good CPR and what's the second one? AED. The AED is coming now. You can look at her feet. She received the shock. And CPR restarted immediately. And this patient survived. So this keeps happening. It's very rare, but because it's most of the time caught on cameras and it happens to famous people, it gets a lot of attention. Now, what's the definition of sudden cardiac death? It's an abrupt, unexpected death of cardiovascular cause in which the loss of consciousness occurs within 1 hour of onset of symptoms, if you have seen it. Somebody saw the collapse, or if people did not see the collapse, usually within 24 hours. So for example, said goodbye to a loved one, in the morning he was found dead, within 6 hours, we still call this sudden cardiac death. In the USA, only 10 to 15 cases happen per year, but gets a lot of publicity. We keep saying it happens during exercise, but actually most cases happen during sleep and rest. But if the cause of death was a channelopathy, an electrical issue with the heart, it usually happens during exercise. Now, if you have a younger patient, or if the death happens at night, usually this is associated with unexplained death, meaning we don't really know what happened. But we have a new name for this entity, the unexplained death. We call it arrhythmogenic death syndrome. And because we assume that this patient had a channelopathy. So boys and young men constitute around 70%, so having a male gender here, it's bad prognosis. If you have the ability to do post-mortem genetic testing, you can identify a gene in 27% of the time. And if you follow the patients of those families, even if you have negative genetic at the beginning, you might be able to find a cause in the family if you keep following them in up to 13% of the time. So following up the families of those patients is also important. Now we have causes of sudden cardiac death. Structural, like aortic stenosis, coronary artery anomalies, cardiomyopathies, and channelopathies, where the heart looks completely normal, but the issue is with the electrical system of the heart. So my focus will be on cardiomyopathies and channelopathies. I'm not going to talk about congenital heart disease. This is a study from New Zealand and Australia. They actually prospectively collected the patients who died suddenly and looked at them from the age of 1 till the age of 35 years. So children and young adults. What's here important for us as people who take care of children, the unexplained sudden cardiac death is most commonly happen between the age of 16 to 20. So young children and or teenagers. The higher incidence that happens after the age of 20, these are explained deaths and mostly related to coronary artery disease. So the vast majority of the cases are unexplained, and the cases here are the explained ones: coronary artery disease, dilated cardiomyopathy, hypertrophic cardiomyopathy. Most of the cases you can see happen during sleep, rest, or light activity. But if you have the sudden death or arrest happening during exercise, most of those patients have channelopathy. So first we can go about cardiomyopathy, which means a disease of the heart muscle. We have hypertrophic, dilated, restrictive, left ventricular non-compaction, and arrhythmogenic right ventricular dysplasia. We talked about hypertrophic cardiomyopathy. It is the most common cardiomyopathy. It happens in 1 in 500 people, but most of those people are actually asymptomatic and found incidentally. They might live all their life without knowing they have it. There is a few percentage of those patients who have malignant hypertrophic cardiomyopathy, which are at risk of heart failure or sudden death. It affects mostly the sarcomeric protein. So this is, you guys know the sarcomere, which is the contracting part of the cardiac cell. As you remember from medical school, we have the thin filament, right? Thin line and the thick one. The thick ones are the mostly involved with hypertrophic cardiomyopathy, like myosin binding protein 3 and the heavy chain of myosin. These are histology of patients with hypertrophic cardiomyopathy. The one here, A, is normal muscle. You can see it's parallel and organized. But the hypertrophic cardiomyopathy, if you look, is very disorganized, and the muscle cell is replaced by fibrous tissue. And if you look at closer at it, all this white is fat and fibrous tissue, and this is with a special stain. So the muscle completely does not look normal. If you do ECG for those patients, most of the time you see a voltage criteria of LVH and T-wave inversion in left leads. If you see T-wave inversion in V5, V6, this is pathologic. You don't see this. So in normal patients, so if you see T-wave inversion V5, V6, you have to investigate this patient more thoroughly. This is an echocardiogram of a patient with hypertrophic cardiomyopathy. You can see very thick cardiac muscle, hyperdynamic, and this is a very thick muscle, puts the patient at risk of sudden death. Dilated cardiomyopathy, the opposite. The muscle is thin, dilated heart, poorly contracting. Inheritance could be autosomal dominant or recessive. Penetrance is age dependent. Usually, the older you are, the higher the risk of you contracting the hypertrophic cardiomyopathy. We have more than 100 genes identified so far for dilated cardiomyopathy. Most of them, genes affected, are also in the sarcomeres, but also in the sarcolemma. Sarcolemma is the cell membrane of the cardiac muscle. Also between proteins connecting the nucleus to the cytoskeleton and the membrane. So many proteins. Most of the common ones are the titin, prelamin, myosin 1, and troponin. Recently, I have some patient with the phospholamban one. This one is very rare, but recently we found one patient. And also the titin one we have seen recently. Surprisingly, this one, the sodium channel protein type A, this protein can give you a lot of diseases. Brugada syndrome, long QT, and can also give you dilated cardiomyopathy. And recently we have a patient with more than 7 members with this mutation, which is something I'm going to talk about soon. So this is an echo of a patient with dilated cardiomyopathy. You can see very poorly contracting, dilated heart. Also on the short axis there, you can see muscle is very poorly contracted. Now, when we think about dilated cardiomyopathy, we think about more of heart failure rather than sudden cardiac death. But the patients who are at risk of sudden cardiac death, those are who have family history of sudden cardiac death, and the ones with arrhythmogenic right ventricular dysplasia, which now comes to the second one, arrhythmogenic right ventricular cardiomyopathy. Inheritance also could be dominant, recessive, or compound heterozygous, meaning more than one gene involved to give you the diagnosis. There is loss of muscle and replacement of the muscle with fibro-adipose tissue. It is difficult to diagnose. We keep having criteria for it, but unfortunately, mainly based on imaging, but a lot of time imaging is still negative, so it is difficult to diagnose sometimes. The adipose tissue and scarring leads to intraventricular conduction delay and electrical instability. Now, if you remember from our medical school, there are things called desmosums, which connect the cardiac muscles to each other, and there are many proteins within these desmosums, and the mutations within these proteins lead to this disease, arrhythmogenic right ventricular cardiomyopathy. This disease is high risk for sudden death, so you have to investigate the family when finding a patient. So this is the desmosum here, connecting two cardiomyocytes, and inside it many proteins like desmoplakin, desmocolin, flavoglobin, and flacofilin. These are the proteins involved in this disease. On ECG, this is something that I have seen missed by a pediatric cardiologist in my training. A patient presented with this similar ECG, and you can see a very small epsilon wave here. You can see it there with an arrow. Sometimes you can really miss it, and a patient was missed after presenting with syncope, and later presented with sudden cardiac arrest after being seen with the pediatric cardiologist. So this is the echo. You can see the right ventricle here. The muscle is replaced by fibroadipose tissue. Again, we don't see this commonly. And now the gold standard, also can be negative, is cardiac MRI. This is the right ventricle here, and you can see the muscle of the right ventricle is not similar to the left ventricle. It's thin, and there's a high water intensity, means there's a lot of fat here. Cannot go forward. Keeps moving between the non-compaction cardiomyopathy. This gets a lot of attention recently. In the past, it used to be underdiagnosed. Now I think it's way overdiagnosed. 35% of actually those patients are normal. It's just a little bit more trabeculated left ventricle. Also, there is no agreement on the criteria to diagnose it. There are more than 8 genes have been identified. Inheritance is very variable. Also, mitochondrial diseases and inborn errors of metabolism have been associated with it. This is an echocardiogram. You can see the left ventricle should be smooth, but there's a lot of trabeculations. So this is the non-compacted part of the myocardium. You can see these recesses, blood coming in and out. If this is a normal heart, this should be compacted actually into capillaries. But this remains, so all of the fetal hearts look like this, but during fetal development, the heart gets compacted. But this one, that's why we call it non-compacted. So it did not have the normal development of the heart. So now we're finished with cardiomyopathies. Now we're going to go to the second one, where the heart looks completely normal to you, are the channelopathies. It can affect both the brain, giving you epilepsy, or the heart, giving you arrhythmia. And these are the most commonly used proteins in leading to channelopathies: potassium channels, sodium channels, and calcium channels. Okay? And we're going to come to them per the disease. We have LQT, Rugada, catecholamine, polymorphic ventricular tachycardia, short QT syndrome, which is very, very, very rare, I'm not going to talk about. Long QT is the most famous one, you all heard of it. More than 17 genes have been identified, but the most common ones are from 1 to 3, which are potassium channels and sodium channel. These are the genes that have been identified so far. The autosomal recessive ones, or where the more than one gene has been involved, are the famous Jarvell-Nielsen syndrome, which can also cause hearing deficit. This is usually lethal disease. So this is a very, I like those pictures. If you look, channelopathies and the risk of sudden death, LQT1 and catecholamine provoke, or polymorphic ventricular tachycardia. Usually males less than 15 years are at risk, and usually sudden death or arrest happen during swimming or competitive sports in these two diseases, type 1 and CPVT. In LQT type 2, which is females, the risk of death usually in females more than 12, and sudden death usually happens with loud alarms. So we actually told those patients not to have alarm in the room, avoid high sounds, or also can happen in females postpartum. LungQT3, which is similar also to Brugada syndrome, it's the same protein affected. Usually death happens in males more than 18 years during sleep time, or postprandial after having a heavy meal or with fever. The highest predictors of risk of death is prior cardiac arrest or syncope and QTc being more than 500. If you have multiple mutations, you are at higher risk of death. Females, they found that the females with LungQT syndrome type 2 are the highest risk of death. How do we treat LungQT syndrome? Lifestyle changes. So avoid medications, and there is a list online that you can find easily. Avoid swimming, especially LungQT type 1. Avoid and remove lamp alarms if you have LungQT 2. CPR training for family. All my families, the parents have CPR training, and they actually have an AED at home. Unless the patient is more severe and have an ICD. We treat them with beta blockers. All those patients are on beta blockers. Sympathetic denervation. Recently, we have one patient who had a sympathetic denervation in SKMC. For patients who are not able to take beta blockers, or despite beta blockers, they're still having symptoms. And ICD placement. Brugada syndrome is more complex than LungQT syndrome. If you look at the ECG here on the right, this is the typical Brugada ECG, which is the J elevation. Immediately after the QRS, there is a point called J point, is elevated with ST segment depression. So this is the Brugada pattern. Sometimes you don't see it on the ECG of the patient. You give them flecainide or arginine, and they can develop this ECG pattern. So sometimes it's not straightforward to diagnose. These are the genes involved with Brugada. It can be confusing because within same families, they found patients who have the gene and have the symptoms, and patients who have the gene don't have the symptoms, and some patients who have the symptom but they don't have the gene within the same family. So it can be very confusing and difficult to counsel. It is a polygenic disease, not a straightforward disease. But sodium channel type 5 subunit A is still the most common one, which shares it with LungQT3. Therapy, avoid fever, avoid large meals, ICD. Recently, they've been doing right ventricular outflow tract ablation for those patients with good success. Medications usually use flecainide or quinidine, and if you have a patient immediately in arrhythmia storm, use isoprenaline. CPVT typically causes syncope during exercise, mainly swimming. Usually in children more than adults, less severe disease in adults. If you do an exercise test for the patient, it's actually looks normal, the ECG before exercise, and once you start exercising, you have many BVCs before going into bidirectional VT and VF. Genetics, 60% are due to ryanodine receptor gene. So I'm gonna actually go into the drawing. These are the area of the cell that causes CPVT. This, the sarcoplasmic reticulum, is responsible for releasing calcium into the cardiomyocyte. And if you have a premature release of calcium, then this might cause a trigger activity and leave the patient having BVCs and arrhythmia. These are the mutations involved. It could be autosomal dominant or recessive, but if you want to know something about CVT, it is due to release of calcium prematurely into the cell. We treat them with beta blocker, no exercise, sympathectomy, and the problem with ICDs with those patients, imagine if you have an ICD, when you receive a shock, your adrenaline goes high, right? So adrenaline actually causes VT in those patients. So you might get another VT episode and gets another shock. And those patients can run out of battery within 1 or 2 days. So it's very difficult to give them ICDs. You can play with the ICD a little bit, not to shock them with VT, only with VF, or to give them something else, we call it overpacing, to get them out of the arrhythmia.
3 minutes, Dr. August.
Thank you. Now, I'm done talking about the causes of sudden death. This is a concept about the post-mortem genetic autopsy, molecular autopsy. If a patient dies suddenly, what to do with the rest of the family? If you can get a blood sample from this patient, you can send it for the most common causes of sudden death, okay, if you're able, and if you have something positive, then you can test the rest of the family. Or you can run through this pathway, how to screen the families if you have sudden death in the family. ECG, history, physical exam, ECG, exercise, echo, cardiac MRI, 24-Holter monitor, genetic testing. If you have the molecular autopsy of the deceased available, they also can guide you through screening of the family. This is my last thing to talk about, is modifier genes. And I have this in my practice. Many brothers, siblings have come to me with the same genetic mutation. Some of them have the disease, some don't, or different severity of the disease. We have children who are dying while their parents are barely affected. So how to explain this? We explain it through penetrance and gene modifier. This is an ECG for two siblings. This one have mild disease, the other one has very severe disease of hypertrophic cardiomyopathy, although they both share the same mutation. So we call this variable expressivity. Same disease causing mutations can have variable clinical presentations or findings. Penetrance is the proportion of people with mutation who express the disease. Incomplete penetrance, you have the genetic mutation but without the disease, and they result from modifier genes. Now the modifier gene can be a very common one, but has a very, just like a less modifier ability, or it can be a rare mutation, but give you a greater modifier ability. It can happen on the same gene, like, the next allele of the same gene, which we call it intragenic, or it could be on a different gene, we call it intergenic. Can give you more or less expression of the disease. It can help you in risk stratification, and this is coming more and more with personalized medicine. So last slide, take-home messages. Sudden cardiac death in children is rare. That's why we presented it here. Large number of those patients remain undiagnosed, but post-mortem testing and family evaluation might increase the chances of reaching a diagnosis. Genetic testing is taking a bigger role in diagnosis, risk stratification and treatment of channelopathies and cardiomyopathies. Multidisciplinary teams are needed when taking care of families with inherited cardiomyopathies and channelopathies, especially when a sudden death has occurred. Thank you so much.
Very informative. Any questions from the audience? Okay, so Rania.
Thank you so much for this thorough and very interesting talk. My question is, you mentioned it's a very rare disease. However, you mentioned it's a very, very rare disease. However, would you think that screening method would be justified and cost-effective in view of the huge impact this is death in a child who is otherwise healthy, who could be actually picked up early, treated, and what type of screening test you would go for?
Oh, you mean population screening?
Yeah.
So population screening for patients who are at risk of sudden cardiac death and arrest. Unfortunately, there is no clear guidelines in the UAE, and each sports authority have their own guidelines. So if you go for the football, actually, it's mandatory for our children more than 14 years to have an ECG and echo and a physical exam by a cardiologist. This is mandated by the Football Association here in UAE. If you go into other sports like basketball, they also, for professional level, they also ask for this. For this, they only just need a clinical examination. In the US, they only want you to do history and physical examination. They don't want to even do ECG. If any of the history or physical examination is positive, then they go for ECG and echocardiogram. If you go into Europe, they do ECG for all patients, and if the ECG is positive, then they go for echocardiogram and other modalities. So we don't have really clear guidelines in the UAE, and we're only following the guidelines from each sport authority.
Thank you. So I was going to ask you about the family. You already mentioned that we screen the sibling and the parents, or just the sibling, or who should be basically evaluated if the event happened?
So if the event happened, the child will screen, so it depends. So you go by history and physical examination, you try to reach this is autosomal recessive, autosomal dominant. But most of the time, if you really suspect retinopathy, you screen all first degree, parents and children. If you can, if you're able to get genetic, we do, as it was mentioned, whole exome sequencing. But ECG and echocardiogram screening to begin with, at least. If you have high risk of other things like CPVT, you do stress testing. If you have suspect other types of arrhythmia, maybe Holter monitor. So it's, I would say, case by case.
Thank you so much. Any other question?
Yeah, there's a question there in the back.
Please, you can have a question there. Yeah.
So right now we're not really screening for modifier genes or doing anything about it. This is mostly based on research, and I think you have to have a very tertiary center who's have a huge genetic team that can help you screen for those. Yeah. Here we don't screen for modifier genes.
Okay. One last question here.
It'll be a quick one. Thank you, Dr. Anas. Very wonderful, comprehensive lecture. And a quick comment, I think it's really interesting that over the last 20 years or so, we have so many genetic mutations that have been identified. Because I remember during residency training, all of this was just in one bucket of sudden cardiac death. You just had no idea. So in terms of, we do see patients where one of the parents or the grandparents or a first-degree relative has had what you assume is sudden cardiac death because they either died during sleep or exercise at a young age. Now, you had mentioned that some of these manifestations can also be age-dependent. So in your practice, if you do the initial genetic screening and the echo and exercise tolerance test, and they're all normal, do you discharge them, or do you do a follow-up every few years just to make sure they're not developing those?
That's very good. I think if you go back here, we follow them till they're adults, and then you can discharge them. So depending on your asymptomatic adults discharge, but if child follow-up based on age-related expression of the disease. So it really depends. I have a family with sodium channel 5. Uncle had diabetic cardiomyopathy, which he can, but died suddenly in his sleep. Now they tested so many family members, including his siblings, and they were positive. Most of them are positive. And even now the kids of the siblings and the kids of the deceased also are positive. But none of them is having dilated cardiomyopathy, none of them. Actually, one of them had an ASD, which I closed in the catheter. So now what to do with those patients? He died at the age of 31. His kids are positive, but don't express any disease. So I'm keeping following them. The adults, we discharge them. Not following them, and I don't think they need to be if they're completely asymptomatic. But that's a difficult question sometimes. Yeah.
Thank you.
Okay, thank you so much, Dr. Anas. On behalf of the committee and the Triban, I would like to present to you this certificate of appreciation. Thank you all. I think with this we come to an end to the session. There is a break, and then you can follow the schedule for, there are parallel sessions after the break. So thank you so much for your attendance. I would like to thank all the speakers for excellent presentation.